okay, or that they measure up. So to measure these up, we're going to go from the angle of the jaw to the edge of the mouth. So this one will be from here to the angle of the jaw, so that one looks about good. If you look at this one, it's way too big, okay? The other way you can measure is from the incisors to the tragus. Again, you go in there, you're like, oh well, it's way above that. Well, this one, much better. Incisors, what did I say? Incisors make the jaw. It's killing me. Yeah, sorry, getting tired. Goodell. So you want to, so we used to put it in this way and go round and down. You can, if you can, go straight down, okay? It will seat and sit in there, and then that should assist us when we're giving our bag to bag more effectively if we had the other airways closed. These are our nasopharyngeal. I'm not sure if you guys have used these, but again, we size them up. So we want to make sure about the size of width of your pinky, so the circumference, the patient's pinky. Nose to tragus, okay? So the edge of the nose to tragus, measure it up that way, okay? Again, it's got an angle. You really want to put this side in if you can, but it doesn't really matter. Choose whichever hole is the biggest, because that's going to be the easier one. So if one's like that and one's like that, go for the side which is bigger. They go not up, they go straight back. So
the reason not up is you don't want to go
into
there. You want to go.
So again, if you shouldn't get much resistance, again, this is a mannequin, but they should have lots of nice moist mucosa. And you're going back down, maybe a little bit of a wiggle, and you push it down, just gently, okay? And again, that'll help your airway to, if I close those up, to bag more effectively. Nice crack.
This guy only has one lung. It's very sad.
Yeah, very sad. Lost a lung. Again, this is, some people say this is a PEEP valve, so we can deliver PEEP with this thing on the bag valve mask. So if we're able to get good ventilation of this patient, so we've got a good seal, it's bagging well, but the patient's still hypoxic, we can give them some PEEP to try and increase their oxygenation. Any questions around any of that? Do you guys want to have a go? If you want, you can have a go at putting these in.
I can tell you where I use it. Oropharyngeal, this one, okay? If somebody's very asleep,
Yeah.
it's got a bite block, okay, which helps. But if you're not so asleep, it touches the back of the tongue. It's going to make you vomit, okay? So it's very good if patient's very, very asleep. It's not so good if a patient's not so asleep. If you're not so asleep, but your airway collapses, so you breathe like, then that one is pretty good because it doesn't, because it sort of ends there, so it doesn't irritate the back of the tongue because it goes there, so it doesn't irritate the tongue, which is there. It goes above there, so you don't vomit. So patients tolerate it much better.
So as they wake up, they usually, it's like having an NG almost in it, doesn't. Once it's there, people who are slightly don't actually, yeah.
But you have to be careful if you're not gentle, and you can get a nosebleed from it, and then you have somebody who does that and he's got blood.
Yeah.
Worse. Okay, so you don't want to make things
So
worse.
if I couldn't get it through and I was getting I wouldn't do it. Like,
Okay.
you know, I might try the other nair first.
Or if you have facial trauma.
No. Yeah. It's also good if this is like because if they're very stiff, this can be good too. Because if I can't get this in, this I can still get in.
Always get the nose in. Yeah. Okay. And
Yes,
very
it's
fat
great.
people, if you can't bag, I don't know if you have very fat people, we have lots. So if you can't bag them because there's so much soft tissue there, Then you do, this one, and this one. This one needs to be lubed.
I know that one I couldn't get him. Yeah.
Needs to be lubed, but without lube, I got there. You can even, we do that.
We do this sometimes. You can put, because you're opening every airway passage you can.
Yeah, because the fat people has too much soft tissue. Do you guys know what I mean? And then you get two hands. So one person does that. Look, you go. So one person does that.
The other person, right.
This is how you do a really fat person. Works with some peep. 10 of peep. I can bag almost everybody like that. But you get tired.
Yeah.
Okay? So, it's a joy. Question? Yeah, go for it.
Go for it. Yeah,
Thì cái trạm này là cái trạm đường thở cơ bản ạ. Thì trong một số trường hợp mà mình úp mát bóp bóng mà không hiệu quả thì mình có thể sử dụng hai cái dụng cụ đây để hỗ trợ. Một cái là eo quay mũi họng và một cái là eo quay miệng họng. Thì cái cách đo thì hồi nãy chị nói là cái eo quay miệng họng mình sẽ đo từ cái khóe miệng này tới cái góc hàm đi, hoặc là tới cái dái tai đi. Còn cái mũi họng thì mình sẽ đo từ cánh mũi và đo tới cái dái tai đi. Thì cái sự khác biệt đó là bởi vì cái này nó khá là cứng, mà khi mình đặt đúng vị trí nó nằm ngay góc lưỡi thì nếu mà bệnh nhân mê á, thì nó sẽ bình thường, chứ nếu như mà bệnh nhân mà hơi tỉnh thì nó sẽ khó chịu và gây kích thích nôn. Cho nên là còn cái này á, thì nó sẽ mềm hơn, khi đặt vô thì nếu bệnh nhân có tỉnh á, thì họ cũng sẽ dễ chịu hơn, nói chung là chịu đựng dễ hơn. Thì nếu mà đặt cái này á, thì cái chiều dài là đo như vậy, nhưng mà kích thước thì sử dụng so sánh với ngón tay út của bệnh nhân. Và khi mình đặt á, thì nên đặt theo cái phương thẳng đứng từ trên xuống, vì nếu như mà mình đặt theo cái hướng đi á, thì nó sẽ đi vô cái tầng của cái hốc mũi á, thì nó sẽ là nguy hiểm. Cho nên là mình sẽ đi từ cái này xuống. Và chị kêu á là nếu như mình có thì mình dùng cả hai cái để mình thông khí luôn. Còn nếu như không có thì một trong hai. Mà sau khi mình thông khí thì cái này mình có một cái van, một cái bíp, thì khi mà mình bổ sung thêm một ít bíp cho ambu thì sẽ cải thiện được cái oxy hóa cho bệnh nhân hơn. Thì rất là rứa rồi. Dạ. Thì anh chị có thử thì anh chị thử. Question là
Last question.
Question's good.
Open anyway back have this one because some habitually don't have pass with this device.
Yes, I know some don't.
Must have hand or maybe
Huh?
must or maybe must have any pass must have this device or maybe have
I don't know.
bắt buộc phải có hay là có thể có
cái này có thể có cái anh này, vì cái này cái thường thường ambu của mình đa số
so
là mình
so-
đều không có cái biết
This
này.
one
Nhưng mà
doesn't
ý là
have.
nếu như mà
Yours is like this.
This one
nên
doesn't have
cái này là
a
không có nè.
Yeah.
Nhưng mà nếu như có thì mình sẽ cải thiện được cái vấn đề không khí của mình hơn. Dạ. Phải có.
vì cái này khi mà để biết bạn biết cao khi mà tháo hở ra thì nó sẽ biết và cái này là tăng áp lực trở ra.
Thế nhưng mà mình bổ sung một ít lượng.
không thấy cái này thường quy.
Dạ, thì cái này
đưa vô để hồi sức cơ bản thấy nó hơi lạ nên mới hỏi.
Thế còn có một số cái loại là
Yeah.
Đa
So
số là mình không có
Dạ, không
cái
có.
doesn't have a peep.
yeah.
Doesn't have a peak. But
Yeah.
these still help, like, you know.
Yeah. So unfortunately, you can't make it. So anesthetics bags can do PEEP, but this can't. If it doesn't have it built in, you can't. It's pain.
And this still, to deliver the peak, you need to have a seal, good seal, because if you have no seal and you dial that up, it's just air going everywhere else.
Tức là nếu mà muốn biết thì mình bắt buộc cái này phải kín. Dạ, khi nó mở ra thì em cũng không có.
I have a question that I work in the emergency department so that to protect the airway. So chin lip and head up is so okay for patient. But why we use this for patient? What situation we would use it?
If we're, so say I'm bagging the patient and I'm not getting a good seal, so say I've readjusted and I'm not getting a good seal, and so it is coming out everywhere.
Okay.
So say I'm getting air and I can't ventilate well, despite I'll try and play with the seal, or I'm not, I'm feeling like it's getting obstructed, then I would use these, because it means that the air you're pumping out is then going into the airway, and you're also bypassing all the soft tissue. So,
Straight to the airway.
yeah, because
okay.
otherwise the tongue might be, say you've got a big, like him,
like him.
So I've got a big lots of soft tissue and the tongue's sitting back,
Okay.
and I'm trying to do this, and the air's just sort of hitting all around and coming back up.
So now it goes.
And then I put this in, the tongue's gone, all that soft tissue's down, and I'm sitting more, I'm sitting at the back behind a lot of that soft tissue and oropharyngeal. And the same with this one, it's getting more, instead of just putting it up here, you're getting the air delivered down here.
Yeah, see? Remember? The air, instead of putting the air there, you put the air there, or you put the air there. So you put it further back.
Okay.
And then you're more likely to ventilate where you want, which is the lungs, not the stomach, and the air not going everywhere else. And you're going to, again, more likely get the oxygenation up, because you're effectively delivering and ventilating.
I often see that when we ventilate like this, and the stomach will inflate. And how do we improve it?
Don't push too hard.
Yeah.
First thing, when I see young doctors, push very hard, lots of air.
Lots of air.
So you want a tidal volume of about 5 to 700, 5 to 800. This is 1.5 liters. If you go 1.5 liters, the lungs fill up and the stomach fill up. So you do that, and you do about 12, maybe if you're very fast, maybe 16. You don't, not too fast, not too hard, because that just goes to the stomach.
Just a quarter of this.
About a quarter.
So you wouldn't ever usually be
we
using
use
both
it.
hands. So you're doing, even if I'm doing a two-handed technique, I'm only ever ventilating usually one, or very gently with two. So less tidal volume and a good seal. So you want to make sure, again, what you mentioned is getting the airway. So we want the air to go into the airway. So if they're like this, you're more likely going to get your air into your esophagus. So you want your airway straight. So you're going to be pushing forward. So and
Head up and chin lip, right?
so that helps get you into the position you want. So you want them in a position that you're delivering breath. So you'll often be sort of pushing, their neck will be going forward and their head will be going back.
So in your mind, you are pulling the face toward the mask. So when you bag somebody, who's an anaesthetist here? You would know this bit. So you're trying to pull the face. There's the mask, and you pull towards the mask. You don't push the mask on the face. You pull the face towards the mask.
Right.
You've heard this before.
Okay, I got it.
Because if you pull the face and you now bag, you're going to bag much better. Because if you push down, all you do is you squish everything up, and the egg doesn't go in.
And getting them into that good anatomical position where you say, like you'd be getting ready to intubate them if they're unconscious. You want to have that pillow so that if they, and having them, you can't do it to this mannequin, but there's some great photos where you want your airway straight, so you're sort of like that.
I got
yeah,
it.
and so getting in the position means the air is going into the lungs and not into the
Is that a
stomach.
common mistake in hospital Vietnam?
Well, it is, and this is, so the problem with, so in the anaesthetists use, you know, a proper T-piece, and that means that if you don't have a seal, you don't get air back, so you know you're not effectively ventilating. These just
Yeah.
cheat, but it means that you're more likely to get less effective ventilation and more insufflation in the stomach, which in the end makes it all hard.
So thank you.
Seal, seal, yeah.
tone of the face, how to manage the airway.
Depends on the trauma. First off,
The face,
yeah.
whole of face.
Big thing of trauma of the face,
Yeah,
can't use this.
yeah.
Okay? Trauma of the face, one of the reasons why I intubate, just coming out to say that. Yeah. So you try, if somebody's got a lot of trauma, you try and pack. You know what packing is? You try to take ribbon gauze
Like string gauze, like,
Yeah.
not, you know.
and try and put that in, and you could try and do that, but my will, I just intubate. Sorry.
Well, yeah, I will intubate
Yeah.
to protect.
Yeah,
Maybe
if
believe
somebody-
into the lung.
Yeah. In my world, I would just, if the face is so that there's problem with breathing, tube.
Yeah.
That's the real answer. If you can't tube, what you can do is try and do this, pack around it and get, but that's just if you can't tube. I can tube, I would just tube it.
If you've lost your facial anatomy, you can't.
Yeah, it's
it
just,
it
Yeah.
doesn't.
it doesn't
You
work
can't-
well.
You can't bag very well
Yeah.
because, yeah, you know,
So-
massive, facial trauma. You're gonna.
So I would try it while somebody who can tube come, because that's actually the answer. Sorry.
Again, it's a bit, trying to bypass the problem, you know. You need to stop the blood getting into the airway, and that's why you need to get some sort of,
Yeah.
find a tube you can put the air down.
I'm scared to the trauma case and control the airway is problem.
No. Two suckers. Fun. It is.
Pat works in the trauma centre.
Yeah,
She
it's
finds it
fun.
It's fine.
I think
I see you can stay a mental health. Why can you help it?
I'm not happy.
Oh.
I
It's like
like being scared.
Yeah, that's why we became ED. Yeah, no. But I think that it's